that?
Yes. Yes.
Okay. So 16-year-old boy, do you want me to read the whole question or?
No, just talk to me. I mean, you can summarize, talk to me kind of, you know, how you chose E and, looking back, what are you thinking kind of went wrong and kind of talk to me a little bit about more of the thought process, I guess.
Yeah, okay. So 16-year-old boy, he comes in, he has this 1 month history of sharp pain of the ring and small fingers of the right hand. So I'm like, okay, some kind of pain. So there's no trauma, no fever, no weakness, nothing like that, no history of serious illness, no medications. So then it goes on to say he plays basketball, pitches for the varsity baseball team, and then he also has a part-time job bagging groceries. So then I'm thinking, okay, there's two things where he's probably moving his hand a lot. Maybe one of those could explain why this is happening. His mom doesn't really matter. Both wrists and hands appear normal. So his strength is 5 out of 5, but the range of motion of his shoulders, of everything is fine. So what's the cause? So I was like, okay, well, they gave you two things here. It was he's pitching, and he bags groceries. But I just remembered from step one, I was like, okay, every time you saw like pitcher, baseball player, the number one thing was supraspinatus muscle. Like that was the muscle that always kind of got injured there. And then I see that he has this sharp pain of his ring and small fingers. So I was like, that's not really supraspinatus, and then also abduction's fine. So that's kind of what took me away, which it was the answer. But that's what took me away from the baseball team. The other thing, I was like, okay, well, maybe it's because he's bagging groceries. Like you're using a lot of hand movements with that, especially if it's talking about the fingers. But then I was like, I don't know, it says part-time. So that's kind of giving me something that it's like not the main cause. So then I was just like, well, if it's not that, it's not that. Maybe it's just some idiopathic cause of this pain. But then they explained that it's ulnar tunnel syndrome, which I didn't realize you could get ulnar tunnel syndrome from pitching and playing baseball. I guess that overuse kind of thing. So
Yeah, yeah. I would say overused, but I mean, if you're talking about a test taking strategy standpoint, right? He plays varsity basketball and varsity baseball, which are rigorous, right? So playing two sports, meaning you're going to put more pain and pressure on your body. So, just with history, you're like, it's probably due to sports, because playing at a high level on two sports, right? That takes a lot of strain on your body. But like you said, occupational task, unlikely, right? Because he bagged groceries, right, part time after school, but most of the time you're holding bags with both arms, right? It doesn't matter if it's dominant, non-dominant, right? And so it's
yeah.
unlikely there. And then when you say idiopathic on a test, you got to be pretty sure that, because idiopathic means we don't know what it's caused by. You know what I mean? So
Yeah.
it's very, it's very odd that he has idiopathic unilateral sharp pain from his right hand. You know what I'm trying to say? Like,
Yeah.
why is it his dominant hand, right? That's why they mentioned he's a right hand dominant person also. So meaning when he plays sports, he's using that hand. So
Uh,
just the best answer here is C. It's not super obvious, I would say, but using kind of a little bit of context, a little bit like he doesn't, he's not a full time grocery bagger, right? And then idiopathic just practically means you don't know what it is. And so on a test, I'm very hesitant to pick idiopathic
mhm.
because if they're asking you, then there has to be some kind of answer, right?
Yeah. Okay. Yeah, that makes sense. So I guess the idea of like the supraspinatus, I shouldn't have like, I guess, grasped onto that. All your reasoning makes sense because like you said, it's varsity, right hand dominant.
Yeah,
And
just on a clinic, a little bit more clinic. I think you have the right idea of thinking like, oh, what muscles or what mechanism can cause this kind of pain. I think I like that train of thought, but take a little bit broader of a history of a sense that, oh yeah, he plays a bunch of sports. He's right hand dominant. Like you might not know exactly kind of what's causing his pain, but you're like, probably sports. You know what I'm trying to say? If
yeah.
this patient came in to see you, you're like, I might not know exactly like what muscle or what motion, but it's probably from your sports. So
Okay. Yeah. Okay. Yeah, th these first like 12. I don't know if it was just me like trying to get back into it, but it was like in this first gap. But anyway, this is just kind of like knowing vocab. I didn't really know what a sentinel event was. What happened was there's a 10-year-old boy. He came in, he went under surgery, and then he was just unresponsive. He was on IV morphine, and pulse was 120. Respiration was at 10. So like vitals were completely not normal. Oxygen saturation was 88%. So anyway, then they give him IV naloxone and then he's fine. So it seems like this kind of like mistake that shouldn't have happened. So I was just thinking negligence. Sentinel event, I didn't realize it was exactly like either a patient dying or some kind of almost serious harm, or which explains this. Their explanation was active negligence could be right, but it's usually an individual, and there's no individual described in this, is what they were
Sure,
saying.
sure. Yeah, I mean, this, like you said, this is more of a vocab thing. I also have to touch up on, some of this stuff because I forget, active negligence makes sense. It's practically usually when they say active negligence, it's usually, like you said, it's a sole person, right? Like the physician was negligent, or the nurse was negligent, or the physical therapist was negligent, right? It's usually a person. You can't really blame the system was negligent,
Yeah.
because actually the system is actually built for a Swiss cheese kind of model where it's like it's very hard to have something really bad happen because, in a sense, the system has multiple checks to prevent something really bad from happening. Does that make sense? So
Yeah.
the system prevents from individuals that are negligent, right? There's going to be sometimes negligence that happens, but other individuals should be able to catch that because the system is, in a sense, created that way. So an act of negligence is usually an individual. Improper handoff, that's like, when shift changes, right? Perioperative risk, I mean, that's like, right, hypothetical issues right before surgery and things like that, right?
Mhm.
I don't know what quality indicator is. I'm not sure what quality indicator is.
Yeah, I wasn't either. A measure of healthcare quality. Okay.
Staffing ratios and things like that. Yeah, I never heard about that. But yeah, I mean, vocab thing, just kind of understand what a sentinel event is, and which means a major harmful event to happen. So
Yeah. And I guess like if there's something like this on the test, hopefully it's along these same lines or in this ballpark of words, and it's not like a whole new set of 5 terms that I'm like, oh gosh, where were these at?
sure, sure.
So So this one essentially was a woman who came in and she had osteoarthritis. She had osteoarthritis. It's describing everything. And so that's what I like kind of hooked onto. But they mentioned this one line, and it says that it's difficult for her to open her medication bottles, shop, cook, and clean. She lives alone. So because it's like this idea of like interrupting her daily activities, even though she has osteoarthritis, the main appropriate like management would be a geriatrics assessment to see like if she's okay to be at home doing all this on her own. Um, but I just hooked on to osteoarthritis and looked at the treatment. But now, even looking back, I feel like the better answer would probably be A, because if she's having osteoarthritis in her, it's widespread, shoulders, joints, hands, and knees, you wouldn't do a
Yeah,
you
yeah,
know what I mean?
yeah, for sure. And so I'm gonna give you some caveats here. Okay.
Yeah.
Um, A is would be a better answer if you're looking for treatment, but in a family medicine ward, which is the one that you're about to take the shelf, right? You got to
Mhm.
think of like preventative medicine and very like holistic medicine, if that makes sense. So all these questions are going to be skewed in a family medicine light. So when you're reading this question and you're looking at the answer choices, right? Like for instance, like orthopedic consultation should be out the window, right? Because a lot of times that's not the first thing you can do, right? Like placement into nursing care facility, you're pawning off the patient, so that's probably not a good choice, right? And this is just based off of the answer choices, not even the stem itself. And then you look at, okay, intra-auricular administration of corticosteroids, that's pretty invasive, right? So even without reading the question, you're like, okay, so family medicine is going to do the least invasive thing, right? They're going to talk, kind of preventative medicine is going to be kind of what the perspective of family medicine is. And also they're very collaborative. So the best answer here is you can never go wrong with a multidisciplinary geriatric assessment, meaning like, multiple people on a team to help assess mental status, mobility, occupational health, things like that. And having this 80-year-old woman trying to figure out what's the best way for her to live her life, right? Making sure that did you assess for dementia, like all this stuff, you know what I mean? And so in a family medicine world, C is going to be the thing that pops out the most for you here, because that practically fits with the perspective of, the shelf that you're taking.
Yeah. So would A be, I guess, like also conservative? What they're saying is that's like not the of utmost importance because she lives alone and all of that. But
Yeah.
would that be more like a conservative approach too?
Yeah, A would be a pretty conservative approach, but it doesn't, like I said, like you said, it only takes care of some of her movement stuff, but it's like, she probably has other issues going on. She's 80. So making sure that you're just not treating something and then not also thinking, oh, does she have dementia? Does she have something else rather than some osteoarthritis? Like what else is causing her to be limited, right? And so that's the whole thing, is to investigate as a team, right, to make sure you're not missing anything. That's practically what this question's trying to get you to get.
Okay. So this one is a woman who comes in and she saw a physician before. They did a stress test. It showed reversible ischemia. So she comes to you or, this current physician, and she doesn't want to do like invasive procedures. So what are you going to do? And I said, repeat the stress thing that she had at the other doctor. But I guess because she already had it with him, they want you to not do anything. I think I was just thinking of like in clinic, there have been other physicians who did a CT or did a whatever. And there's been situations where we've been like, we'll just go ahead and repeat that today. We'll just go ahead and repeat. So I was just thinking, okay, she said a new physician, repeat it. But I guess not.
Yeah, so let's talk about this. So on 4 months ago, right? I mean, that's a very short time. So she had a cardiac stress 4 months ago. And so the question is, if you're and just remember, a cardiac stress test is an expensive test, right? It's not a cheap test, right? And so you have to ask yourself on a monetary standpoint, for one, why are you ordering the test? And for two, is it going to give you new information to do something different? Okay, those are what you're asking yourself. So number one, if she had one 4 months ago and you get one now, it's probably going to tell you the same thing. Would you agree?
Yeah.
Probably not going to change, right? So you're not getting new information. So that's a bad ordering of a test. And number two, even if you got that, what would be the treatment? Well, probably a cardiac cath to kind of help open that up. But if she already does not want to do that, then the imaging itself is pointless. You know what I'm trying to say?
Yeah.
Because you only so this is something you get to learn as you're a resident and also as an attending, is that when you order tests or do some kind of imaging tests, labs, etc., right, you got to ask yourself, does that change your management after you get that piece of information, right? So if the answer is no, right, no matter what the result comes back, but it doesn't change your management, then it's like, well, should you be getting the test? You know what I'm trying to say?
Yeah.
So that's like the argument, right? So like, let's say they have a $10,000 test, and if the test shows up positive, then you would recommend X, right? And if the test shows back negative, then you would recommend this. But the patient already says, if it was positive anyways, I wouldn't want that anyways. So then if you get the test, it's like you're kind of back in the same situation. You know what I'm trying to say?
Yeah. And
So
so
yeah.
I was just gonna say, is it pretty confident that like in 4 months, because I think when it says reversible ischemia, could that could like go away in 4 months or not really? It's
No,
pretty,
reversible ischemia just means that she has partial blockage of her coronary arteries, and that when she is stressed, meaning either medically stressed or physically stressed, when her heart's beating more, then she starts getting some muscle ischemia, right? So she has angina, is practically what I'm saying. She has stable angina, meaning that her heart is not completely dead. It's just the more she exerts herself, the more that muscle doesn't get oxygenated blood. Does it make sense?
Yeah. And so that will still be there in 4 months. That's
Yeah,
like
that's still going to be there
technically,
because that coronary artery is blocked like I don't know what like 95% or whatever it is. It's not 100%. There's still some blood flow, but the only way to get rid of that is, like I said, something invasive to clear that up, right? Some bypass, something, right? So if she's not wanting to do that, then that's going to stay there, because atherosclerosis or coronary artery disease, that stays there for a long, long time unless you do something about it.
yeah. Okay. That makes sense. This one I get. I mean, and you just do a basic pregnancy test.
Mm-hmm.
But I was thinking TSH. I think I was thrown off by during the past year, she's had weight gain. And I was like, okay, well, if you past year, like you gain weight in 9 months. So if it's going over 9 months, it must be something else. And then also it said her last period was 3 weeks ago. So I was like, she pregnant? Like, I don't know if she'd be pregnant. But I think like what I've learned in clinic too is just you kind of always do a pregnancy test just to rule it out. Um,
Yeah. I mean, so think of it like this. I mean, it also happens in surgery too. We always run pregnancy tests for surgery also because, you know, you don't want to miss, someone that is pregnant and you put them under anesthesia that could be, you know, teratogenic, right? And, mess with the fetus, right? And then that's a huge lawsuit. You know what I mean? And I know that's a legal aspect, but for here, the history, they tell you that she's sexually active with one male partner and they use condoms inconsistently. So that line by itself, disregarding whatever, you got to run a pregnancy test,
yeah.
right? Because you don't want to miss it, right? Because being pregnant can change a bunch of things, right? And the last thing, right? The last thing you want to do is go down a rabbit hole, treat her with a bunch of medications, and next thing she's pregnant 2 months down the line, and you've been giving all this, fetal toxic medication to treat something that everyone would have looked back as like, why didn't you run a pregnancy test?
Yeah.
So,
Okay. So even though it says like she gained weight in a year, what you're saying, they use condoms inconsistently, kind of like just trumps that. You
yep.
just want to confirm. Okay.
Confirm that. And even if they, I mean, to be honest, in real life, even if they say, oh, I use condoms consistently, but they're not on like some kind of medical birth control, before you go deep diving, just make sure you're not missing pregnancy. Very
Yeah.
easy thing to do. Just pee, get a beta HCG, and then if it's negative, good, then you can start going, all right, let's start working you up for something else, because you have something that's physical in the chart that says patient is not currently pregnant. So
Yeah. Right. Okay. It's like one by one. They just have diabetes, and I was saying do their serum glucose, but you want to examine their feet. And I think they ruled out B because they're already getting the hemoglobin A1C, so it's kind of redundant.
yeah,
So
yeah,
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 want to
and
look.
the A1C is going to be the best test to monitor someone that's already diagnosed with diabetes. You know what I mean? So because it's a three month average of how your blood glucose is. But yeah, every time you see a patient that's already diagnosed with diabetes, you got to check their feet. It's like kind of malpractice if you don't, because if they get paresthesias, they get ulcers, things like that, they can get really fucking sick. Excuse my language, I didn't mean to say that, but
Yeah,
also sorry.
yeah, you're
Also on
good.
top of that, right? If it gets necrotic and etc., right? That's how patients lose limbs when they're diabetic. So you got to check their feet.
Okay. Yeah. And I guess if they didn't have hemoglobin A1C that they were doing, what I guess you would still check their feet over.
Yes, you got to check their feet. Yeah.
Okay.
That's part of your physical exam. So just imagine when someone sees you in clinic, the first thing you don't say, hi, let me get blood work. No, no, no. You say, hey, how have you been doing? You ask them their history, right? And then, obviously review systems, and you go to, their physical exam, right? So this is before any of your plan is in place. So your physical exam and good history with physical exam is always going to be your answer first. It's not going to be a lab value. You know what I'm trying to say?
Yeah.
So
Okay. Yeah, that's true. Yeah, always a physical exam. Okay. This otitis media, I was thinking amoxicillin was, I just psyched myself out. I was thinking amoxicillin was too simple, and I was like, I knew I'd seen C somewhere. But yeah, duh. Otitis media you treat with amoxicillin.
Yeah,
Um,
it's kind of interesting because if you do the if you look at the data, so the most common infections for sinusitis and like strep throat and ear infections, so all ears, nose, and throat issues is usually by your basic strep and strep pneumonia and H influenza and Moraxella, right? That's kind of the order. And ironically speaking, for some reason, the ears, the bacteria that you get ear infections with, they haven't become very resistant. So amoxicillin works just great. But if you get sinus infections, Augmentin now is the antibiotic by choice, and strep throat a lot of the times amoxicillin is also a little bit resistant, so augmentin or clindamycin will work for a strep throat too. So it's kind of the last thing in the ears, nose, and throat section that amoxicillin still works super super well. So you don't have to you don't have to treat with anything stronger, usually go away.
Okay. Yeah, there was actually a patient that we had who they diagnosed with sinusitis and they treated with Augmentin.
Yeah.
So with sinusitis, like she came in and she was like obviously tender sinuses and she was having congestion. How I guess what differentiates that from just like an upper like a viral infection would be like the tenderness of the sinuses because with viral infection you have your congestion, you have sometimes your rhinorrhea, you have your watery eyes. So,
So great question. So there's a big debate on it, right? Because actually most acute rhinosinusitis is actually caused by viruses. So if you look in the literature, we probably overtreat viral sinusitis with augmentin. Okay. Because there's a very distinct guideline of like, oh, if you have more than 5 days and it gets worse with fever, pus, etc., then that's considered like bacterial in nature, or it goes on for longer than 10 days. Like there's specific guidelines to it. So I would say that we probably overtreat, right? Because most people that come into the clinic, especially walk-in clinics, they're going to be like, oh, I have a bacterial sinus infection. And so most physicians will just say, okay, here's a round of augmentin. And then they say, oh, they feel better. But do they feel better because it was just a virus and they waited another 5 days and it got better? Or was it truly a bacterial that got rid of by augmentin? You know what I'm trying to say?
yeah.
So they sometimes do ask on family medicine shelf that they'll have these symptoms, but it's only been for 2 or 3 days. They have a 99 or less than 100.4, right? Meaning that it's not a true medical grade fever, right? And it's been for 3 or 4 days. They feel congested, some facial pain and pressure. It's some rhinorrhea. What is the most likely diagnosis? It's going to be viral, not bacterial.
Yeah, there's actually a question down the line where it had all of that, but it said, and we'll get to it, but it said yellow green discharge. And every single thing I had seen where it's like green or it's usually bacterial, the viral ones have been like clear discharge, clear rhinorrhea, clear. And so I ruled out viral and went with bacterial, but I guess viral can also have green yellow discharge.
Yeah. So viral, people always have the mistake with viral rhinosinusitis. They think the color of your sputum is like very specific, meaning that, oh, if I see pus, then has to be bacteria. Not necessarily. And one of the great examples that I can give you is that seeing exudates in the tonsils, does that mean that it's bacterial?
No.
The answer is no, actually. So actually, a lot of viral tonsillitis can also give you exudates too, which is why I think the newer guidelines is you're supposed to swab everyone, even if they meet 5 out of 5 CINTR criteria, because there's a lot of viruses that look like bacterial in nature. You know what I mean? And
Does it?
so, you know,
Yeah.
it's these small little things that as we learn more and more, they'll tend to test more because The point that they're trying to make is it might look like a bacteria, but unless it's like, it's more severe, things like that, then it's not truly bacteria, if that makes sense.
Okay.
So
Yeah, that makes sense. Because mono, that's caused by EBV, and you
yep.
sometimes have exudates with mono, right?
Yeah, it has tons of exudates. They have really bad lymphadenopathy. They can get really fatigued, have fever. If you go by Centaur criteria, that is a strep infection that you don't have to swab and give, you know, antibiotics, but that's mono. You know what I'm trying to say? So
Yeah. Yeah. Okay. That makes sense. This one I initially chose this, but then switched to kind of a weird answer because I thought, like, looking at AST, ALT, I thought it had to be 2 to 1 to be like an alcoholic cause. And then it like goes on to say, you know, in a ratio of 2 to 1 or greater. So they have that explanation too. So I don't know why that's not 2 to 1, but when you look at the question, it's I feel like his only issue really is this AST ALT, so that's why I initially chose it. But
yeah,
no,
that's it.
yeah,
Don't overthink it too much. Okay, 2 to 1 is, that's the textbook, ratio. But you gotta know that in life, like if someone sees an AST that's higher than an ALT, but they're both elevated, they're not gonna be like, oh, it's not 2 to 1, so it must be something different. You know what I'm trying to say? Um,
yeah,
and this guy says that he drinks 2 to 4 alcoholic beverages daily. So remember, for men, it should be 1 to 2. So he's drinking double the amount that he should be drinking per day.
hmm,
So, you have your history, you have everything. So it has to be that.
yeah, okay. This one I'm still kind of confused on. So what modifications would be most beneficial to this patient? So you have a man, he has type 2 diabetes, hypertension, he's a new patient. He takes metformin, HCTZ, he smokes 1 pack of cigarettes daily for 20 years, 142/82 blood pressure, and then for his vitals, or sorry, his labs, hemoglobin A1C is 7.8, and then I saw glucose was 135, creatinine's fine. Cholesterol was a little high, but these two are fine. So for me, when I was looking at this, I saw A1C. Usually, if they have diabetes, less than 7 is what you want it. So 7.8 isn't terrible, but I was just immediately like, okay, that's a little high. And then glucose a little high, but he does have diabetes. So I was thinking, okay, increase metformin, and we did that in clinic. I remember there whatever was a little high, and they're like, okay, we're gonna increase your metformin today. So I just kind of went off of that. Um, but I guess I know smoking is a risk factor for coronary artery disease, but is this
Yeah.
related to coronary artery disease because his cholesterol is just a little high?
No, so this is a holistic question. What I'm trying to say is it's a question that, once again, this goes to the perspective thing about family medicine that we talked about before. It's kind of it's not, this answer is not directly related to this question in particular. Practically, they're saying which would be the most beneficial to this patient, just holistically as a patient. And if right, smoking causes all sorts of crap, right? Congestive heart failure. I mean, not coronary artery disease, right? COPD, high blood pressure, increased risk for clots, increased risk for head and neck cancers, etc. So practically, what they're trying to ask you with this patient in particular, which would be most beneficial to this patient's health. So E is not incorrect. Like, controlling his diabetes better is not incorrect. But which one is worse, having diabetes that is slightly uncontrolled or smoking a pack a day? Smoking is way worse holistically.
Okay.
Does that make sense? That's what they're trying to ask him, this question. It's like, oh, did you know that smoking is worse in a sense than slightly uncontrolled diabetes, right?
Mhm.
Obviously his glucose is not like 400, which might be a different thing because he could die. But 135, yes, it's elevated, but is it off the freaking roof? No. But smoking 1 pack of cigarettes every day for 20 years, and he's going to continue to do that, he's definitely killing his body. So
Yeah. Okay. Yeah, I think so. I guess that line, like of his history that he smokes a pack a day. He's done it for 20 years. Kind of had he not smoked cigarettes, I wonder if that would still be the correct, like, would it still just be a holistic approach and you would choose A if
Um,
he,
what do you mean? If he didn't smoke one pack of cigarettes a day, is that what you're saying?
yeah, like, are they honing into the fact that like he's like that's a significant part of his history?
Yeah, that's significant. And also just in general, knowing that smoking causes so many issues. Like for him, diabetes plus smoking equals, vascular inflammation, which is not good. Blood pressure elevated probably from his smoking too, right? Because that causes issues too. So smoking causes all sorts of stuff, right? And so they're just trying to say, especially, and then if you ever see smoking cessation on this test, it is, I would say 80-90% going to be the right answer.
Yeah, I agree. There were like two other questions. I was like smoking cessation. It was the right answer.
Yeah.
So, okay. This one I get. I'll take ownership of this. This was just a woman with osteoarthritis. What are you going to treat it with? NSAIDs is like number 1 for osteo, but she has kidney disease and coronary heart disease, and you don't use ibuprofen with kidney disease. So you want to go with PT. So
Yeah.
that was
So,
just me. Oh, go ahead.
oh, I was going to say one more thing. Okay. Perspective when you take family med, going back to it, remember, preventative medicine is very key. It's like one of the key points in family medicine. So if you see physical therapy, you see occupational therapy, if you see rehab, if you see, anything with therapy, it's going to be a good bet that it's the answer. Okay. Like I said, remember, you're taking a family med shelf, so you should put yourself like in their perspective. They're all about prevention, right? Not throwing on more medication, but how can you practically get people off medication and live a healthy lifestyle? That's their whole specialty in a sense, right? And so anytime you see, like I said, smoking cessation, stop drinking alcohol, physical therapy, occupational therapy, right? Reduction of loud noise exposure for the ears, things like that. Those are going to be like, oh, you can just see it from a mile away. It's going to be the answer. So,
Yeah. There was one on the first test that was like they have a nodule in their thyroid, and in internal med it was like fine needle aspiration or like ultrasound or something. And so that was an answer choice, but the right answer for the family med one was palpate palpate the neck. I'm like, well, duh. I when I took it, I was like, that's kind of simple. But you're right, it's like it's family med, so it's more conservative.
yeah. So just know every specialty is, different. Like for instance, if you saw this scan on an orthopedic, right? Like on general surgery, it could be the answer is like, that's a bad joint. Let's freaking replace it, right? Because every specialty is different, right? So the perspective is different. And so that's why I said there's a little bit of, a test taking strategy when you know which rotation you're on. And this one just happens to be family med. So you just got to put yourself like, if you see smoking cessation, that's probably the answer. If you see physical therapy, probably answer. Like these are things that you get used to when when you understand that that's their perspective.
Yeah. Okay. This was just, I misread the growth curve. So he's 4 months, 15. I've never read one of these before, so I kind of went quick, and 4 months and then 15 pounds. I was looking at kilograms. So I was like way up here. I was like,
Oh yeah. Yeah, I
I was
got
like,
you, got you.
yeah, that's too rapid. But yeah, when you do it correctly, he's like 50th percentile. So it's fine.
Gotcha. Good.
But now I know that. That was just a mistake. This was just, I read all the values and everything lined up with iron deficiency, but ferritin, I just kind of missed. Ferritin should also be low in iron deficiency, but it's
Yep.
normal.
It's
So
normal. Yeah,
they were
has to be
saying
thalassemia.
thalassemia. I just didn't
Yep.
realize thalassemia minor, it was normal. Um, but yeah, no, even if I didn't know that, it's not normal in iron deficiency. So
Good.
there's that. This was silly. This was basically DEXA scan showed that she had osteoporosis. In the moment, I saw that they had started her on calcium and vitamin D. So I was like, why would you need to do like a dronate? And then they mentioned her cholesterol. So I was like, yeah, address the cholesterol if they're already doing calcium and vitamin D. But I think you need to do, in this case, something that's addressing the osteoporosis more directly than just supplements.
Okay. Yeah. Yep. Negative 2.8 is a lot. That's like really bad. That's like, I think it's like 2.8 standard deviations in the bad direction. If I think of that correctly, but I could be
Yeah,
wrong. But
you're
that's what I
right.
think that's what it means.
I
So
think
that
it's
means that she's like in the bottom, I don't remember the freaking bottom 10%, of like bone density, which, she's very prone to, breaking her bones, right? So
yeah, because I think it's uh greater than negative 2.5 is considered osteoporosis. So
gotcha.
this one, so they go to, is this the dentist one? Yeah, so they go to the dentist. There's this concept that if you go to the dentist and you've had some kind of like prosthetic heart valve or something, you get prophylactic treatment so you don't get endocarditis. And so she has mitral valve prolapse and mitral regurgitation, but I misremembered it, and it's only prosthetic valves or some kind of like heart transplant, not a simple like heart murmur that you do the prophylaxis. So that's why there's no
Yes.
prophylaxis.
Yeah, and this is something actually I would say relatively new. I can't remember how many years ago, maybe 10 to 20 years ago, but it's because they did these studies and dentists would give prophylactic for everyone, like, everyone under the sun. So then you're just giving out, amoxicillin like candy, and then that's why you get bacterial resistance. And then the question is, do we need to start doing this? And then they had studies that said only those that are at super high risk, like you said, prosthetic valves, they had endocarditis before,
Yeah.
heart disease that had surgery, things like that. But just a simple murmur, right? You're not running, antibiotics for everyone, because as you get older, almost everyone has a murmur, right? So
Yeah. Okay. Um, this was a OB question. It was like ectopic pregnancy, and there's a question I got before that was like, in order to determine ectopic pregnancy, you measure the beta HCG, and if it doubles, then it's a good sign that it's a pregnancy, and if not, so that's the idea I was going off of. But now in retrospect, I mean, they did a urine pregnancy test that was positive, so it's kind of, I guess it doesn't make sense to just do another one.
yeah,
Um,
no, and you have to ask which one is more definitive. Yeah, I understand what you're talking about with the beta HCG, but to figure out like an ectopic pregnancy, meaning it's in a different place, then the best way is to actually visually see it, right?
yeah,
So,
yeah. And then yeah, this one I just didn't know. The patient had low platelet count, and you just continue with the dental extraction.
oh
I
yeah, yeah,
I didn't know that fact.
yeah. I mean, if you 110,000 is actually pretty high still. Yes, it's lower than normal, but it's still high. I mean, you'll see this more and more, but I'm not sure if you bumped into a patient where they have true, thrombocytopenia, where it's like less than 30,000. I've seen somebody less than 5,000, and you just touch them and they bleed, right? But 110,000, not big deal. It's all
Okay.
it's all relative. I know that you're looking off of the normal, but 110,000, there, yes, they have less platelets, but it's not going to make a significant difference in bleeding. But once you get under like 30,000, under 10,000, 5,000, then you start bleeding significantly. So
Okay. Almost done. Yeah, this is the one I was talking about. I was like, okay, viral, 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 and then I see yellow green, and so that's why I automatically ruled out the symptomatic care and went straight for antibiotic. But we kind of talked about it. You can still have the yellow green discharge even if it's just viral.
yeah, and if you look at it, right, 2 day history, so it's not a long time. It's usually over 5 days. And then no fever, right? And so he has normal temp, right? He also has some inflammation of his tonsils, but no exudates. He has some postnasal drainage, but yellow green. So color doesn't mean anything. You got to combine everything together. So The majority of his physical exam is, pointing towards a viral infection. So
Yeah. Okay, because if it were bacterial, it probably would have a fever. You would have lymphadenopathy. Would
yeah,
you? Yeah,
yeah,
you would.
some maybe some lymphadenopathy, pain and pressure in your face. Lasts for, they'll usually say 5 to 10 days. It's been going on and it hasn't gotten better, right? Might see yellow, green, white drainage from the nose, right? All those things will lead you, like, they'll be very, how do I say this? They'll be very descriptive if it's bacteria. They're not going to be like, oh yeah, everything looks normal except he has yellow, green drainage. That's viral. You know what I mean?
Yeah. Okay. And this one makes sense. I was yeah, renal artery stenosis. They just have this like resistant hypertension.
Yeah.
Um but I was like looking at the creatinine and I saw it was normal. So I guess you can have renal artery stenosis and creatinine be normal.
Yeah, so renal artery stenosis is the artery that actually feeds the artery that feeds the kidneys, right? But when you're talking about creatinine levels, that's the kind of the filtration system, the glomeruli that functions on excretion and things like that, or filtration. And so for the most part, your kidneys can still be decent, but your artery that is kind of feeding the blood supply is just kind of constricted. And so the way the kidney responds to that is secretes a bunch of, aldosterone and things like that to keep absorbing sodium to keep that blood pressure high in order to get enough blood supply to the kidney. You get what I'm saying? So it's like this ever cycle. But yeah, over time, if it gets bad enough and you somehow cut the blood supply off to the kidney, then it can kill the kidney. But you can have normal creatinine.
Okay. Will you ever have abnormal and renal artery stenosis in
Yeah,
case
that's
like
what I'm saying. If it gets bad enough where you're not getting enough blood supply to the kidney, then your kidney gets ischemic, and if your kidney gets ischemic, then it can't filter as well. So it's possible, yes.
okay.